Our next speaker is Kelly Brown.
Today I will update the board regarding Public Health Ontario's latest data on post-vaccine myocarditis incidence, which continues to show troubling increases. As of the last meeting of this board, Public Health Ontario reported approximately 400 cases of post-vaccine myocarditis, half of which occurred in males aged 12 to 29. In the 4 weeks since, Public Health Ontario has reported an additional 66 cases, with 40 of those occurring in 12 to 29-year-old males. There are now approximately 230 myocarditis cases in this one age-sex cohort, occurring at a rate of 1 in 6,000 males. Post-vaccine myocarditis risk increases as the age category decreases, and considering only 12 to 17-year-old males, the risk is closer to 1 in 5,000 males. These boys are receiving Pfizer. Dr. Kieran Moore, Ontario's Chief Medical Officer of Health, on September 29th, addressing the Pfizer over Moderna recommendation, indicated, quote, "Even in the phase 3 trials of the major vaccines, we didn't see any signal for myocarditis. It's only when you have adverse event following immunization reporting that you find these very rare events," unquote. As a reminder, Pfizer's global trials included less than 2,000 children aged 12 to 17 globally. Ontario's young boys and men should not be treated as involuntary trial participants and deserve better protection for their chief medical officer of health, who has been cavalier in his support of mandatory COVID-19 vaccination in these young ages. The post-vaccination risks outlined above far exceed the risk of ICU admission or death from COVID-19 infection in these young ages. Regarding the risk of COVID-19 associated myocarditis, at the last Board of Health meeting and subsequent City Council meeting, Dr. Davila stated that the risk of myocarditis was much higher following COVID-19 infection than after vaccination. However, quality data supporting this assertion is lacking, and studies on this topic only emerged to any degree later in 2021 after we began vaccinating young members of the community. If COVID-19 associated myocarditis was observed to a troubling degree during the pandemic, it is likely more alarm would and should have been sounded. In closing, it seems that this board continues to ask young boys and men, who have their entire lives ahead of them, to take known and quantifiable risks for little or speculative benefit. Vaccinating young boys and men for COVID-19 is a bad trade and should be halted immediately.
Thank you very much, Kelly. We will now try to go back to Margot Boyd.
Thank you. My name is Margot Boyd. I have a postgraduate degree in health sciences from what is now known as the Della Lana School of Public Health at U of T. My area of interest was the determinants of health, and I grew to understand the imperative that policy must be data-driven and evidence-based. If I were a city councillor, I would ask why there appears to be an actually negative protection rate of the vax against COVID-19 in both the Israel and UK data. I would ask them to explain why the latest UK data set shows a negative protection rate in the 30 to 80 plus years age groups for cases. I would also ask public health why they now state that COVID-19 actually causes myocarditis in children. We know that this statement has no basis in fact. Sick Children's Hospital set up a clinic for children who have gotten post-jab myocarditis this summer, 2021. There was never any need for a children's myocarditis clinic for well over a year after COVID-19 began, only when the injections commenced. In fact, a cardiologist who receives cardiac referrals from sick children, who shall remain nameless to protect them from the CPSO, stated they had seen 0 cases of COVID-19 caused myocarditis in children. A false narrative was generated. Who benefits? This situation is serious, as the well-being of children hangs in the balance. We are no longer inoculating the vulnerable and the elderly, who make up the vast majority of the COVID-19 fatalities. For some reason, the Board of Health, are choosing to jab a population which the evidence shows does not get severe COVID disease, does not die from COVID, and does not spread COVID because of their low viral titers. The inconvenient truth is that there will be irreversible damage and fatality in the children resulting from mRNA jabs if you do not change course and follow the actions of other countries that have modified and withdrawn injections as a result of internationally known and recognized data. Just like Dr. Moore removed Moderna from the male 18 to 24 age group, he will have to remove it from the 12 to 17 age group after we see the heart damage we know will occur according to available evidence. Public Health has
Margot,
done
you're
the public...
just coming up on 5 minutes. If I could ask you to wrap up in a sentence, please.
Oh, okay. I'll 2 sentences. Public Health has done the public a tremendous disservice by not telling parents that their children have an over 99.99% infection survival rate, having chosen instead to fearmonger and frighten them into jabbing their children with products that have already been withdrawn elsewhere in the world. Why?
Dr. Donald Welsh.
Great, thank you. Pleasure to address the Toronto Board of Health. My name is Dr. Donald Welsh. I'm a member of the Robarts Research Institute and professor of physiology at the University of Western Ontario. Note that respiratory vaccines aren't true vaccines in the sense of completely blocking infection, disease, and transmission. They should be viewed as time-limited therapeutics designed to moderate disease. Pre-existing immunity exists in the population, especially young children, the latter being of exceedingly low risk to hospitalization and death, and some experts even use the words close to zero. This brings us to childhood vaccination, the 5 to 11-year-olds, and the new generation of CoV-2 vaccines. Given this group's exceedingly low risk of hospitalization and death, the rationale for mandatory vaccination is weak and counter to the principles of precision medicine. Further, the side effects of vaccine deployment, often termed vaccine injury, must be considered. While most are often mild, injury in rare instances can extend to death. This is problematic for childhood risk-benefit calculation, as serious outcomes are also remarkably low. Vaccine injury is a topical issue, as given the marked prevalence of myocarditis in young males, and this concern heightens at younger ages. And this is given the fact from what we know from past vaccine deployments. Whilst COVID-19 vaccines are especially prone to this phenomenon, we don't really know why, but we should consider dosing as an issue. Without going into the details, this isn't a trivial issue for new genetic-based vaccines. So while dosing remains an issue for childhood vaccination, there are additional concerns, the most important being that the immune system of a child is distinct from an adult. They rely more on lung-based mucosal immunity than the acquired immune system, the latter of which is being trained by natural infection and often vaccines over many years. There is concern, especially with the COVID-19 vaccines, that pushing early development of acquired immunity could weaken lung-based mucosal immunity in children. This would be deleterious, and it is why we should be very cautious of a one-size-fits-all approach to vaccination. Unintentional consequences will and do occur.
Our next registered speaker we have is Derek Moran.
So kind of a traditional vaccine, that's something that we think of in the back of our minds as it's an agent, a biological agent that blocks the infection process, blocks the disease process, and then also blocks transmission. Now, respiratory vaccines, that's what we sort of call them. They don't effectively block either the infection or the transmission over long periods of time. What they do is they tend to moderate the severity of the disease. Because they don't do all three of those, we tend to call them leaky. And that leakiness has consequences into the future. It can often promote variant development or mutations. And those mutations can often get around the normal, let's say, viral defenses of your body or induced by a vaccine. It's the COVID vaccines themselves that are leading to mutations that are leading to the variants of the virus. COVID-19 vaccines designed to elicit neutralizing antibodies may sensitize vaccine recipients to more severe disease than if they were not vaccinated. Vaccines for SARS, MERS, and RSV have never been approved, and the data generated in the development and testing of these vaccines suggest a serious mechanistic concern that vaccines designed empirically using the traditional approach consisting of the unmodified or minimally modified coronal viral spike to elicit neutralizing antibodies, be they composed of protein, viral vector, DNA, or RNA, and irrespective of delivery method, may worsen COVID-19 disease via antibody-dependent enhancement, which is also known as ADE.